Seniors, doctors are wrong about blood sugar levels for older adults. A startling truth may be unveiled today, a revelation that could provoke anger and deep concern. It appears that your medical doctor might be utilizing inappropriate blood sugar targets for your specific needs, not due to any professional incompetence on their part, but because current medical guidelines often apply a uniform approach to all diabetic patients, irrespective of their age. The precise blood sugar target recommended for a vibrant, healthy 35-year-old individual is frequently the identical target your physician endeavors to achieve for you, whether you are 68, 75, or even 82 years old. This widespread practice, unfortunately, has been shown by recent research published just this year to be profoundly dangerous for older adults. Maintaining excessively low blood sugar levels in senior patients can lead to more detrimental outcomes than allowing slightly elevated levels. This includes an increased incidence of falls, heightened confusion, more frequent hospitalizations, and tragically, a greater risk of mortality. Yet, a significant number of doctors remain unaware of these critical findings, continuing to adhere to outdated guidelines that could inadvertently be causing harm. Dr. Claire Whitmore, a cardiac surgeon with 2 decades of experience working intimately with diabetic patients, has observed firsthand the severe consequences when blood sugar targets are misaligned for older adults. She has witnessed the profound devastation caused by falls, the alarming episodes of dangerous hypoglycemia, and the progressive cognitive decline, all stemming from doctors' insistence on achieving the same stringent blood sugar control in an 80-year-old frail diabetic as they would in a healthy 30-year-old. Dr. Whitmore is prepared to disclose the specific blood sugar targets that should genuinely apply to you, tailored to your age and overall health status. However, those crucial numbers will not be immediately revealed, as it is imperative to first grasp the underlying reasons why doctors employ these incorrect targets and the cascade of negative effects that result from such practices. Readers are encouraged to share their age and current fasting blood sugar target provided by their doctor in the comments section below. For instance, one might comment, age 73, doctor says keep fasting under 100. This collective information helps to illustrate the prevailing targets being recommended. Consider the unsettling narrative of Harold, a story that serves as a stark warning. Harold, at 78 years old, had lived with diabetes for 12 years. His doctor expressed considerable pride in the perceived success of his diabetes management. "We must prevent complications," his doctor would consistently reiterate during every visit. "Tight control is absolutely essential. We aim to keep your fasting blood sugar below 100 and your A1C under 6.5. The more rigorously we control it now, the healthier you will remain in the long term." Harold, trusting his physician implicitly, would nod in agreement. His doctor meticulously followed established protocols, adhering to what were considered the latest guidelines, employing a combination of multiple medications to achieve what appeared to be perfect control. Harold's regimen included metformin twice daily, glyphosate in the morning, and insulin at bedtime. With this comprehensive treatment plan, Harold's laboratory results on paper appeared exemplary. Fasting blood sugar consistently between 95 and 105, and an A1C of 6.3. His doctor would proudly present these results, beaming, "Perfect control. This is precisely where we want you to be. Your numbers are superior to those of most diabetics half your age." Harold, in turn, would smile, nod, and accept the commendation. Yet, beneath this veneer of success, he felt profoundly unwell, absolutely terrible, in fact. Despite his discomfort, he hesitated to voice complaints. His numbers were, after all, perfect. He reasoned that his symptoms must be attributable to something else, perhaps simply the inevitable process of aging. "That's just what happens when you're 78, isn't it?" he thought. The unsettling episodes began subtly. A few times each month, Harold would awaken in the dead of night, enveloped in a strange sensation, shakiness, profuse sweating, and profound disorientation regarding his whereabouts. His wife, Ellen, would rouse to find him perched on the edge of their bed, looking bewildered. Harold, are you all right?" she would inquire, gently shaking his shoulder. He would respond with unfocused eyes. I don't know, I feel weird. Ellen, through these repeated occurrences, had learned to promptly check his blood sugar. She would prick his finger, watching the meter display readings as low as 55, sometimes 60, and occasionally a dangerously low 52. Reacting swiftly, she would fetch him juice, urging him to drink it and sit by his side until his blood sugar normalized and his mind regained clarity. "You had another low," she would inform him. "Your sugar was 55. The frequency of these episodes escalated over time, progressing from once a week to twice, then 3 times a week. Harold continued to experience these nocturnal events, with Ellen consistently coming to his rescue. They established a routine: juice kept on the nightstand, blood sugar checked upon signs of confusion, juice administered, and then patient waiting for recovery. At his subsequent appointment, Harold brought up these troubling occurrences to his doctor. "I've been experiencing these episodes," he explained, detailing the nocturnal low blood sugar, his wife's interventions with juice, and the fact that it was now happening 2 or 3 times a week. His doctor, after reviewing Harold's blood sugar log and noting his A1C of 6.3, declared, "Perfect. Your overall control is excellent." The doctor continued, "These occasional lows are manageable. Simply keep glucose tablets readily available and consume a snack before bedtime. We certainly don't want to reduce your medications and forfeit this beautiful control we've painstakingly achieved." Harold, deferring to his doctor's expertise, nodded. He began consuming a snack before bed every night and strategically placed glucose tablets in his car, his pockets, on his nightstand, and beside his recliner. He developed a heightened vigilance, obsessively focused on preventing lows while simultaneously striving to maintain the strict control his doctor demanded. Yet, the episodes did not cease. Instead, they intensified. Harold began experiencing them during daylight hours as well. He might be engrossed in watching television when a sudden shakiness would overtake him. While working in his garage, a wave of confusion would wash over him. He would check his blood sugar, consistently finding low readings, 58, 62, 65. He would take glucose tablets, wait for the symptoms to subside, and then attempt to resume his day. Ellen was gripped by terror. "This simply cannot be right," she emphatically told Harold. "You are experiencing dangerous low blood sugar 3 times a week, sometimes even more frequently. This is utterly unsafe. You absolutely must inform your doctor that this approach is not working." Harold complied, returning to his doctor and presenting the alarming frequency of his episodes, elaborating on how it was severely impacting his daily life, how he lived in a constant state of fear when alone, and how Ellen was compelled to monitor him continuously. His doctor reviewed the data, his expression initially concerned, but then his gaze fell upon the A1C, still 6.3. "Your average control remains excellent," the doctor reiterated. "We merely need to fine-tune your snack timing, perhaps incorporate an additional snack in the afternoon. However, we have diligently worked to achieve such a low A1C, and I am reluctant to reduce medications and risk seeing it creep back up." This frustrating cycle persisted for 8 arduous months. 8 months of Harold living in perpetual dread of his blood sugar plummeting. 8 months of Ellen's unceasing vigilance. 8 months of glucose tablets, juice, and frantic middle-of-the-night rescues. 8 months of his doctor commending his A1C while entirely dismissing his debilitating symptoms. Then, one Tuesday afternoon, Harold was driving to the grocery store, a routine errand a mere 5 minutes from his home. His thoughts were occupied with Ellen's shopping list: milk, bread, eggs. He paused at a red light, and then he felt it, that familiar tremor originating in his hands, the beads of sweat forming on his forehead, his thoughts becoming increasingly disjointed and foggy. "No, not now, not while driving," he pleaded inwardly. He instinctively reached for the glucose tablets in his cup holder, but his hands were trembling too violently. He couldn't manage to open the container. The traffic light shifted to green. He continued driving, desperate to reach home, to pull over somewhere safe. But the shakiness intensified, his vision blurred, and his thoughts scattered like leaves caught in a gale. Where was he headed? Why was he in the car? He couldn't recall. He tried to maneuver to the side of the road, but his body failed to respond as commanded. Everything seemed to unfold in agonizing slow motion. Then the world abruptly plunged into darkness. His car veered left, crossed the center line, and collided head-on with oncoming traffic. The other driver had no opportunity to react. A deafening crunch of metal, a shower of shattering glass, airbags deploying with explosive force. Harold regained consciousness in the emergency room. His arm was broken, ribs fractured, his head throbbed excruciatingly, the result of a severe concussion. He had no recollection of the accident, nothing after stopping at that red light. The ER nurse, upon his arrival, had checked his blood sugar, 48, severely hypoglycemic. This was the reason for his loss of consciousness, the cause of the devastating crash. The other driver lay in the adjacent emergency bay, suffering from a broken leg and possible internal injuries. Harold could distinctly hear the man groaning in pain. Harold had caused this. He had injured an innocent person, someone simply driving to work, all because his blood sugar had plummeted dangerously low. Tears streamed down Harold's face. This was his fault. His own body had betrayed him. The tight control his doctor had so vehemently insisted upon had nearly cost him his life and had severely harmed someone else. An endocrinologist visited Harold the following day. She meticulously reviewed his case, examining his medication list, his blood sugar logs, and the documented frequency of his hypoglycemic episodes. Her expression was grave. "Mr. Harold," she began gently, "your primary care doctor was excessively aggressive with your diabetes control. You are 78 years old. You have a well-documented history of frequent hypoglycemia. You are currently taking 3 medications, including insulin and a sulfonylurea. Your targets were far too stringent for an individual in your specific situation." Harold, bewildered, interjected, "But my doctor assured me my A1C was perfect, 6.3. He said that represented excellent control." The endocrinologist slowly shook her head. "For a 78-year-old with your medical history, an A1C of 6.3 is, in fact, dangerous. We are going to implement significant changes. Our new aim will be a fasting blood sugar of 110 to 130 and an A1C somewhere around 7.5 to 8.0. For someone of your age, preventing hypoglycemia is unequivocally far more critical than achieving perfect numerical values." A surge of anger, hot and bitter, coursed through Harold's chest. His voice trembling, he uttered, "So, the tight control my doctor insisted on almost killed me. I've been enduring dangerous lows for 8 months. 8 months, and he refused to adjust my medications because he desired my A1C to remain under 6.5. Now I'm in the hospital with broken bones, and I've caused an accident that seriously injured another individual." The endocrinologist's expression was one of profound sympathy. "I am truly sorry this has happened to you. The established guidelines for blood sugar control in seniors are markedly different from those for younger adults. Your primary care doctor was unfortunately applying young adult targets to your case. This is a common occurrence, regrettably. Many doctors are either unaware of or choose not to follow age-specific guidelines. However, the research is abundantly clear. Tight control in older adults leads to more harm than benefit." Harold closed his eyes, reflecting on 8 months of profound suffering, 8 months of paralyzing fear, 3 times a week waking up disoriented and terrified, Ellen's constant worry. All of it could have been prevented. All of it was a direct consequence of his doctor's insistence on perfect numbers on paper, without due consideration for how those numbers were being achieved. "Why didn't anyone inform me sooner?" Harold whispered. "Why did it require a car accident for someone to recognize that my blood sugar targets were fundamentally flawed?" Harold's harrowing experience serves as a powerful demonstration of why age-appropriate blood sugar targets are not merely advisable, but essential. What constitutes perfect control for a healthy 35-year-old represents dangerous overtreatment for a 78-year-old. Yet, the vast majority of primary care doctors fail to make this critical distinction, aiming for identical targets, irrespective of a patient's age. If you are experiencing hypoglycemic episodes similar to Harold's, you are encouraged to comment with "having lows." This is a definitive indication that your current blood sugar targets are excessively strict for your age and personal circumstances. Harold's story unveils the very real dangers. But why do doctors persist in making this mistake? Why do they apply the same targets across all age groups? The answer lies in 5 deeply ingrained false beliefs about blood sugar that lead them to overtreat older diabetics. These beliefs are so entrenched that even when presented with compelling research, doctors do not always alter their perspectives. False belief number 5 suggests that lower blood sugar is inherently better, regardless of age. This conviction originates from seminal studies, recognized by names such as DCCT and UKPDS. These studies were truly groundbreaking and revolutionary, definitively proving that stringent blood sugar control effectively prevents complications in diabetics, including kidney disease, blindness, and nerve damage. They transformed diabetes care forever, and their conclusions were absolutely correct for the population studied. However, a crucial detail often overlooked by doctors is that these studies involved individuals with average ages ranging from 27 to 53 years old, young, healthy diabetics who had decades ahead of them during which complications might develop, and whose bodies were robust enough to tolerate aggressive treatment. The results, therefore, do not necessarily apply to frail 80-year-olds grappling with multiple complex health issues. Nevertheless, many doctors fail to make this vital distinction. They generalize, assuming that lower is always better for everyone, regardless of whether they are young or old, healthy or frail. This assumption is fundamentally flawed and exceptionally dangerous. Research specifically conducted in older adults paints a dramatically different picture. The Accord trial, for example, specifically investigated intensive blood sugar control in older diabetics already afflicted with cardiovascular disease. The study aimed for an A1C below 6.0 in the intensive control group compared to a standard control target of around 7.5. Alarmingly, the intensive control group exhibited higher mortality rates, more deaths. The trial was prematurely terminated because tight control was, in effect, killing people. Rereading that statement underscores its gravity. Tight blood sugar control in older adults with pre-existing health problems was not helping them, but actively causing their demise. Despite this compelling evidence, many doctors continue to believe that lower is always better. They have not updated their understanding, have not thoroughly reviewed the newer research, or, if they have read it, they do not believe it applies to their specific patients. Consequently, they continue to treat elderly diabetics in the same manner as they treat young diabetics, leading to suffering or even death for patients like Harold. False belief number 4 asserts that preventing long-term complications should remain the paramount priority at all ages. From a purely logical standpoint, for a 35-year-old diabetic, preventing long-term complications is entirely rational. You are proactively avoiding kidney disease that might manifest in 2 decades, preventing blindness that could occur in 25 years, and mitigating nerve damage that would take 15 years to become severe. A 35-year-old is highly likely to live long enough to experience these complications if their blood sugar remains uncontrolled. Therefore, aggressive treatment aimed at preventing these future issues is indeed appropriate. The risk-benefit calculation clearly favors tight control. However, an 82-year-old diabetic faces a very different set of priorities. They may not live another 20 years. The very complications that doctors strive so diligently to prevent might never develop within the patient's remaining lifespan. Meanwhile, the immediate risks associated with tight control are undeniably real and present. Falls induced by hypoglycemia can be fatal within days. Confusion stemming from low blood sugar can lead to perilous medication errors, debilitating accidents, and a tragic loss of independence. These immediate risks are manifesting now, today, this very week. Yet, many doctors apply the same future complication prevention mindset indiscriminately to all ages. They are essentially preventing complications that the patient may never live long enough to develop, while simultaneously causing immediate and tangible harm through hypoglycemia. For an 82-year-old, the priority is not preventing blindness 2 decades hence. The priority is preventing falls today, avoiding confusion today, today, maintaining independence today, and living well today. However, attempting to convey this perspective to a doctor who has been trained for 3 decades that preventing complications is paramount often proves futile. It simply does not align with their established framework, which is entirely constructed around averting future complications. Asking them to prioritize the present over the future feels inherently wrong to them, even when it is demonstrably the correct approach for the patient's immediate well-being. False belief number 3 posits that A1C is the most crucial measurement, irrespective of any other contributing factors. A1C provides an average measurement of blood sugar over a 3-month period. It is undoubtedly a valuable and highly useful tool, offering a broad overview of blood sugar control. However, it is fundamentally just an average, and averages can be deceptively misleading and even dangerous. An individual might exhibit a seemingly perfect A1C of 6.5, a beautiful number on paper. Yet, this average could be concealing dramatic fluctuations, blood sugar levels plummeting to 45 multiple times a week, only to surge to 200 as the body attempts to compensate. The recurrent lows are inherently dangerous and potentially life-threatening, but they are statistically averaged out by the intermittent highs, resulting in a number that appears flawless. This was precisely Harold's predicament. His A1C of 6.3 appeared perfect, to his doctor's delight. But Harold was experiencing severe hypoglycemia 3 times a week. The A1C simply did not capture this critical detail. It only presented an average. In older adults, preventing these dangerous lows is significantly more important than achieving a low A1C. A much more important consideration, an A1C of 7.5, coupled with stable blood sugars and no instances of hypoglycemia, is demonstrably safer than an A1C of 6.5 achieved through aggressive treatment that precipitates frequent lows. It is safer, better, and ultimately more appropriate. Nevertheless, many doctors fixate solely on the A1C number without genuinely considering the mechanisms by which it is attained. They observe a 6.5 and automatically perceive it as success. They often fail to inquire about hypoglycemia or the patient's overall sense of well-being, instead merely noting the number and moving on. This approach is entirely backwards. The numerical data should serve the patient, not the other way around. False belief number 2 states that the same medications and their corresponding doses are appropriate for all ages. It is a known fact that many diabetes medications can induce hypoglycemia. Sulfonylureas, such as glyphosate and glyburide, actively lower blood sugar regardless of its initial level. Insulin functions in a similar manner. These medications do not merely reduce high blood sugar, they lower blood sugar universally, even if it is already within a normal range, or more perilously, already low. In young adults with robust kidney function, the body possesses the capacity to compensate effectively and efficiently clear these medications from the system. Doses that are perfectly safe for a 40-year-old might be entirely appropriate. However, older adults universally experience a natural reduction in kidney function as part of the normal aging process. It happens to everyone. The kidneys become less efficient at filtering, causing medications to accumulate and build up in the system. A dose of glyphosate that is safe for a 40-year-old can become excessive and dangerous for a 75-year-old. The medication remains in the system for an extended duration, exerting a more potent effect and thereby causing hypoglycemia. Despite this physiological reality, many doctors continue to employ identical dosing approaches across all age groups, using the same protocols and algorithms, treating a 75-year-old in the same manner as a 40-year-old. Given that their kidneys do not function identically, their medication doses absolutely should not be the same, yet they frequently are. And finally, false belief number 1, arguably the most perilous of all, is the conviction that objective numbers hold more significance than how the patient truly feels. Medical professionals are rigorously trained to place their trust in objective data, laboratory values, blood pressure readings, imaging results. These are quantifiable, reproducible, and possess a scientific validity. In contrast, subjective symptoms are often perceived as vague, unreliable. Everyone feels tired sometimes. Everyone experiences bad days. Symptoms are often not considered data in the same rigorous sense. This training is so deeply ingrained that it becomes incredibly challenging for doctors to overcome. They can, quite literally, be unable to perceive beyond the numbers to the actual person sitting before them. Harold's doctor observed impeccable numbers on paper, an A1C of 6.3 deemed beautiful. Meanwhile, Harold was suffering from hypoglycemia 3 times a week, feeling utterly miserable, facing a high risk of falls and accidents, and living in a state of perpetual fear. Yet the doctor fixated on the numbers, not the symptoms. When Harold reported his problems, the doctor would glance at the A1C, which remained perfect. Therefore, the doctor concluded the issue could not possibly be related to the diabetes management. It must be something else entirely. This reasoning is completely backwards. In older adults, symptoms and overall safety are paramount, far outweighing the importance of achieving perfect laboratory values. Numbers that cause you to feel terrible are inherently not good numbers. Numbers that lead to frequent hypoglycemia are unequivocally not safe numbers. Numbers that systematically diminish your quality of life are the wrong numbers, regardless of what established guidelines might state, and irrespective of what a lab report indicates. If the numbers are causing you harm, they are fundamentally incorrect. However, try persuading a doctor of this. Attempt to convince them that their cherished perfect A1C is, in reality, harming you. They have been meticulously trained throughout their entire careers to relentlessly pursue perfect numbers. Asking them to accept higher numbers often feels like a professional failure to them, even when it represents a genuine success for the patient's well-being. These 5 false beliefs collectively drive doctors to overtreat older diabetics, employing excessively strict targets, prescribing an abundance of medications at doses that are too high, dismissing crucial symptoms, and focusing exclusively on numbers, thereby causing significant harm in the process. Reflect on which of these 5 beliefs you find most detrimental. Comment Belief 5 or Belief 1, or whichever you believe causes the most widespread problems, to indicate what resonates most strongly with you. The specific blood sugar targets that are genuinely appropriate for you are yet to be revealed. Those crucial numbers are forthcoming. But first, it is essential for you to recognize the 6 distinct signs that indicate your current blood sugar targets are excessively strict for your age and personal situation. You might currently be in a situation akin to Harold's without even realizing it. You may mistakenly believe that what you are experiencing is normal, merely an unavoidable aspect of living with diabetes, or simply a part of the aging process. However, this is not the case. It is a clear warning sign that your targets are inappropriate. Sign number 6 is frequent hypoglycemia. If you are experiencing blood sugar drops below 70 mg/dl more than once or twice a month, your targets are unequivocally too strict. Full stop. If you are experiencing severe lows, defined as below 55 mg/dl, even a single instance indicates your targets are definitively and severely too strict. Hypoglycemia is inherently dangerous. It can lead to confusion, falls, accidents, seizures, and even death. It is not an issue to be simply managed with quick snacks and glucose tablets. It is a critical condition that demands prevention through a deliberate loosening of blood sugar control. In older adults, preventing hypoglycemia holds greater importance than achieving a perfect A1C. This is not merely an opinion, but is supported by extensive research and is consistent with recommendations from authoritative bodies such as the American Diabetes Association for Seniors. If you are experiencing frequent lows, your targets are fundamentally incorrect. Sign number 5 is unexplained falls. If you are experiencing falls more frequently without any apparent clear reason, low blood sugar could very likely be the underlying cause. Hypoglycemia induces symptoms such as dizziness, weakness, confusion, and impaired balance, all of which dramatically escalate the risk of falling. Many falls observed in diabetic seniors are, in fact, attributable to unrecognized low blood sugar, rather than solely to balance issues or weakened muscles. These falls occur because blood sugar drops too low, precipitating dizziness or confusion at an inopportune moment. Your doctor might attribute these falls to aging, arthritis, or general deconditioning. However, if you are diabetic and experiencing frequent falls, the possibility of low blood sugar must be thoroughly investigated. Sign number 4 is worsening confusion or memory problems. If your cognitive clarity has diminished, or your memory problems have become more pronounced since your doctor tightened your blood sugar control, this is not a mere coincidence. Low blood sugar can directly impact your brain function. Recurrent hypoglycemia damages brain cells. Each episode can lead to the death of a few neurons. While a single episode may not cause noticeable damage, frequent episodes accumulating over months and years can have a cumulative effect. Chronic, low-grade hypoglycemia, which you might not even consciously perceive, can lead to progressive cognitive decline. Your doctor might attribute this to dementia, normal aging, or Alzheimer's disease, but it could very well be a consequence of blood sugar levels that are too low, depriving your brain of essential glucose, damaging neurons, and thereby causing the very cognitive decline that many mistakenly believe is an inevitable aspect of aging. Sign number 3 is constant hunger, or the incessant need for frequent snacks to prevent lows. If you find yourself needing to eat snacks between every meal and before bedtime just to prevent your blood sugar from plummeting too low, it is a strong indication that your medications are too potent and your targets are excessively strict. Consider this critically. You should not require a constant intake of food simply to stave off hypoglycemia. This is not indicative of normal diabetes management. Instead, it signifies a struggle to counteract dangerous side effects stemming from overtreatment. If you are compelled to eat every 2 hours to prevent your blood sugar from dropping, something is fundamentally amiss. Your treatment regimen is overly aggressive. Sign number 2 is feeling terrible despite achieving good numbers. If your A1C registers at 6.5, yet you persistently feel exhausted, weak, shaky, or generally unwell most of the time, it is highly probable that your blood sugar is consistently running too low. Good numbers that make you feel absolutely terrible are not, in fact, good numbers at all. They are misleading numbers. Numbers that may appear successful on paper but utterly fail in the context of real-life experience. Quality of life is paramount. Feeling well is paramount. The ability to function effectively is paramount. Numbers that systematically diminish your quality of life are unequivocally the wrong numbers, irrespective of what official guidelines may assert. And sign number 1 is requiring assistance from others due to episodes of low blood sugar. If your spouse or other family members are regularly compelled to rescue you from hypoglycemic events, your blood sugar control is excessively aggressive. If they are routinely checking your blood sugar during the night, if they are continuously monitoring you for symptoms, or if you cannot be left alone because of the inherent risk of a low, then you have experienced a significant loss of independence. Your safety is compromised, and your quality of life has been severely eroded. This situation is utterly unacceptable. Your targets must be substantially relaxed. If you recognize any of these 6 signs in your own experience, your blood sugar targets are demonstrably incorrect for you. You are being overtreated. It is imperative to initiate a serious conversation with your doctor about deliberately loosening your control. Please comment below how many of these 6 signs apply to your situation. Whether 1 sign or 3 signs or any other number, this information is vital, helping to elucidate the prevalence of suffering caused by overtreatment. Before disclosing the age-appropriate blood sugar targets genuinely supported by research, it is important to mention a valuable resource being developed to provide comprehensive guidance for your specific situation. A free private community called Senior Health Life Daily is currently being built. Within this community, detailed protocols not found elsewhere will be shared. Excitingly, once 100 people join, the first complete guide dedicated to blood sugar management for older adults will be released. This is not generic diabetes advice. It is age-specific guidance. It will cover appropriate targets for individuals at 65, 75, or 85 years old, offer strategies for communicating with doctors who insist on excessively strict control, explain how to safely adjust medications, and provide methods for preventing hypoglycemia while maintaining adequate blood sugar control. Everything you need Details on how to join this community will be provided at the conclusion of this video. But first, it is essential to understand what your targets should truly be and how to collaborate effectively with your doctor to achieve these appropriate goals. Now, the moment has arrived to reveal the age-appropriate blood sugar targets, meticulously based on current research and expert guidelines. These are not personal opinions, but rather recommendations from esteemed organizations such as the American Diabetes Association, the Endocrine Society, and geriatric medicine specialists, derived from extensive studies involving thousands of older diabetic patients. First, a crucial distinction must be made. Blood sugar targets are not solely dependent on age, but are also critically influenced by overall health status. A robust, active 75-year-old with no other significant medical problems can safely tolerate stricter control than a frail 75-year-old suffering from heart disease, kidney disease, and dementia. This differentiation is logical and intuitive. Therefore, targets must be individualized, considering several key factors: your age, any coexisting medical conditions, your estimated life expectancy, your personal risk of hypoglycemia, your cognitive function, your living situation, and available support systems, whether you are still capable of driving, and your personal preferences. All these elements collectively contribute to determining truly appropriate targets. With this contextual understanding, here are the general target ranges for older adults, informed by extensive research and established guidelines. For healthy older adults aged 65 to 75, exhibiting few other medical problems, possessing good functional status, and having a long life expectancy. Fasting blood sugar 90 to 130 milligram DL. Before meals 90 to 130 milligram DL. Bedtime 110 to 150 milligram DL. A1C target 7.0% to 7.5%. These targets are marginally more relaxed than those for younger adults, yet still represent a reasonable level of control. The primary objective for this group is to prevent long-term complications, while simultaneously avoiding the risks of hypoglycemia. For this relatively healthy cohort, tight control continues to offer benefits without incurring excessive risks. For older adults aged 75 to 85, who may have some medical conditions, exhibit moderate functional impairment, or possess an intermediate life expectancy. Fasting, blood sugar 100 to 140 milligrams DL. Before meals 100 to 140 milligrams DL. Bedtime 120 to 160 milligrams DL. A1C target 7.5% to 8.0%. These targets represent a more relaxed approach. The central focus for this group shifts from preventing distant future complications to actively preventing immediate harms, such as hypoglycemia, falls, and confusion. Studies indicate that an A1C of 7.5% to 8.0% in this demographic provides adequate blood sugar control without the inherent risks associated with more aggressive treatment regimens. For frail older adults over 85 bordeaux, or those with multiple serious medical conditions, a limited life expectancy, advanced dementia, or who reside in nursing homes. Fasting blood sugar 110 to 150 mmDL. Before meals 110 to 150 mmDL. Bedtime 130 to 180 mmDL. A1C target 8.0% to 9.0%. These targets prioritize comfort, safety, and the absolute avoidance of hypoglycemia. For an individual living with advanced dementia or a terminal illness, there is simply no discernible benefit to pursuing strict blood sugar control. The objective is to merely avoid symptoms stemming from excessively high blood sugar while emphatically preventing any instances of low blood sugar. The paramount priority is the quality of the patient's remaining life, not the prevention of complications they will likely not live long enough to experience. You are encouraged to comment on where your current situation aligns with these targets. Comment, "Doctor, too strict," if your physician is advocating for tighter control than these suggested ranges. Comment, "About right," if your current targets are consistent with these guidelines. Comment, "Doctor, too loose," if your control is significantly more relaxed than these ranges would indicate.